Right.
Yeah.
Now, is that covered through the state program? Do you have coverage for the dental, or is that private pay in Virginia?
We have patients that have their own health insurance, but we also have we do a lot of we have a lot of our programs that are covered through grants.
I see. Well, so that's interesting because we're looking at obstacles, and as we kind of go through this, in some ways, this is maybe sort of like a kind of a conversation just between the group of us here. It's small and relatively intimate, so we've had a chance to talk to each other. One of the things that I did during the last week is to actually go back, and actually yesterday I spent a lot of time doing this. I went to one of the family practice administrators who's in charge of a clinic in town. Then I went to a dental school and talked for 2 hours, and then I went to a senior administrator in a living situation. What I was interested in is what are their obstacles that they face today, and there's a couple of things that I haven't heard before. One was, and they all voiced this, and that'd be interesting if what you feel on this, is that one of the obstacles is the lack of geriatricians or MDs or DOs, and also lack of dentists that are trained in special needs or in geriatrics. Do you feel that shortage in Virginia? Where I came from, and mind you, I just joined this company. Maybe I've been here maybe 5 months at the most, and but where I came from, we did not have dental services. So in that sense, I'm not sure what on that end. But here, be honest with you, we try to be very open to, we offer services to anyone, even the people that cannot pay. And so, I personally, I haven't heard of any problems for our patients getting the service. But I'm also not the nurse manager here. So I know that we don't have DOs. I don't believe that we have DOs here at Neighborhood Health. I see. And how long has the clinic been integrated in integrated medicine? Is that something that's been part of the program there for a period of time? Well, I believe they've been, well, I know that Neighborhood Health has been around for at least 20 years. I see. Okay. Well, that's great. So that helps, and it's well, you've actually come from two different, a clinic or an area where you had no dental health, and then now you have integrated dental health. You can be a source of wisdom for all of us because you've kind of been in both worlds. So, Chris, could you advance the slide for me?
Yes, and actually, I think we had another person join, Stephanie. Can you hear? Can you hear us?
Yes, I can hear.
Great. So today we have Dr. Len Brennan, who is speaking today on readiness for caring for older adults, and so he's actually had queried the attendees a little bit prior to starting, and so we're going to get started, and I'll advance your slides, and hopefully, there you go. Okay, thank you, everybody.
Thanks. So, Stephanie, where are you from, and is your clinic integrated or in the process of integrating? Have you been involved with these, or what's happening in your world?
Well, honestly, I work for a community health center, federally qualified health center in southern Idaho. We have 8 medical clinics, 6 dental clinics, 4 behavioral health clinics, and 2 340B discount pharmacies. So I'm not sure exactly what kind of other clinics are on the call. I thought this would be a good topic to learn a little bit more of as part of our patient-centered medical home model. So, that's kind of our makeup. We're over kind of a large rural area in south central Idaho.
That's great.
But we do have a lot of older folks that work with our care managers.
And do you provide a lot of older services for older individuals, dental?
Well, I wouldn't say that they're like carved out for older people. We have a lot of elderly patients. We kind of are comprehensive. We do the full range of preventative and immediate care, chronic care management, that kind of thing. So when you say, older patients, we don't really have like a certain patient populations carved out or anything, or services for those patients per se.
Well, that's great, because I think the clinics that you're involved with, I think they're sort of on the edge, a great edge of where dentistry kind of should be going, because you do provide such incredible care. Well, great. Well, it's nice to meet you, Stephanie. So one of the things that I wanted to look at today is we're looking at obstacles to care. And I've been involved in a lot of clinics and changeovers. And one of the things that I find can be the most challenging when people are getting involved in or sustaining integration is that the whole system has to buy in. So you have to believe that you can make a difference medically if you're a dentist, and dentally, vice versa. And that is can be a very difficult role. And I think sometimes the success of these clinics, and I suspect you all have experience with this, that the leadership makes such an important part, because they have to carve out time for education and for finances. And if you have the leadership and you have that can develop the team, I think that's what happens when you can change that culture. In a lot of the states, only 17 states really have coverage for dental in their state programs, which leaves a huge portion of the United States without coverage for seniors, over 70%. So it is, and to make this change, it's difficult for that buy-in. And it can be also difficult for the team members, which you can all, I think, kind of verify this, is that when you're making a change, people are afraid of the change because they're looking at what does that mean for me in terms of more work, is it going to be more successful? Once you're in that integration, it seems to work well. So I think that's probably the greatest obstacle, is that initial culture change of how do we change things, make it differently, and still make it a team play. Could you change that next slide for me, Christine?
Yes.
Now this slide here really is just data in terms of, when I was looking at the obstacles of care, what I looked at is that the clinics that were out there and reviewed what they found as obstacles. So part of this conversation today is really to look at not what I look at obstacles potentially, but your feedback would be great, but it's also the feedback from 1,500 or more clinics. So could you advance that again for me? Thank you. These are the typical obstacles that we see, and I suspect you may find these similar in your clinics, and it'd be interesting to chat with you about this. The ones that the health policy from the ADA, the Institute, looks at as being the greatest obstacle of care has always been finances. And what we have seen is, over the last 20 years, the group that is that's away from dental care as seniors over 65 is about 70% of that population. And even though we've had more clinics opening, the number of seniors over 65 that actually receive dental benefits have been decreasing. Now, statistically, if you look at just the number overall in terms of our seniors seeking care, the seniors that are seeking care is that elite group of 27% that have finances that can access care. So their services are actually increasing, but the bulk of the Americans, 70+% of seniors, do not have access to care. And so when we look at these other obstacles to care, I'm sure that every area of the country has certain issues in terms of transportation and health issues and workforce issues. But finances is by far the number one, and I think where we can make the biggest difference in terms of how we treat our seniors in terms of care in the future is to deal with a financial question. I think that, Stephanie, the clinics that you work in, I think, do a great service because it changes that model where you're inviting seniors in that can be lower income so that their services are, they have access to the services. One of the other very, hello? Somebody else on the line? Oh, I thought I heard a question. The second that I think is very, very important is the perception of need. So, and the patients that come into the medical clinic or to, it could be through nurse practitioners or for other types of care facilities, it's very important that that's a great place for integration. Because if a medical professional will look at a senior, even if in that group that has a difficulty affording care, if the recommendation from the medical facility is to receive or you need to get a checkup, that may put that group of seniors back into the dental system. So we'll go through a few of these in a second, but could you advance that again for me, Christine? This is a great graphic on why seniors tend not to come to the dentist. And this is from the American Dental Association Health Institute, Policy Institute. The number one reason, 49%, is cost. Now, again, that is for most of the population. Many times there was always a philosophy in dentistry is that if we can show that dentistry is worthwhile, they will come. Well, that hasn't happened, and the person who runs the health clinic, Dr. Pachusic, looked at that as a piece of data that really has never shown to be true. So the most important thing is that we can take care of issues of cost and perception of care. And that may change one of the major obstacles for care for seniors. The others that I think that we deal with, because I heard, I think both clinics, Stephanie and Rosie, you were talking about chronic conditions and things like that. All those can certainly influence care and the integration of care. But those are the two reasons I think we have access to be able to do something with. Could you advance that slide for me? Again. This slide here is there are a number of different guides, because one of the obstacles for many dental and medical clinics for getting involved in dental care, it's where do you go to access information, good information that gives you the nuts and the bolts of how you integrate care in your clinic. And there are some wonderful resources. This is a resource and a guidebook, and it's supported by DentaQuest and a number of different healthcare organizations. But it's a booklet that if you don't have it, I think it's very worthwhile getting. And what it does, it introduces everything from the introduction of integration, how it works and why. It talks in detail about the framework, how you prepare for implementation, and that covers everything from training your staff, what auxiliary staff you need, what's the physical environment going to look like, how you do your electronic records. It gives you tremendous amounts of information. And I think this is just one example of one terrific source for you to look at. There's also great sources to the national, through NOAA that has just a tremendous implementation guide. And so it's worthwhile looking at these before you try to reinvent the wheel, because it has great things on that. Any questions on that? Or when you have developed implementation guides in your clinics, what did you use and what did you find you had problems with? What about yourself, Rosa and Stephanie? Were there any issues when you were?
I'm not sure what you're asking. When we implemented what?
When you went. Pardon me. What I was interested in is. Hello. Hello.
Yeah, you're cutting out. I'm not hearing very many words.
I'm getting an echo on my side.
Okay.
Hello? Hello?
I can mute it again. That's about the only time I can hear you when you speak, I think.
Okay, that's fine. Oh. So we'll continue to the next slide.
Okay.
Great. When we're talking about the greatest obstacle care is financial for a lot of patients. One of the things that sort of happened is knowing that older seniors really have a hard time getting into a dentist because of that need. Where they end up is in the emergency room, or they could end up getting preventive services that are covered, through integrated medical health centers. And most Medicaid programs will now reimburse for preventive oral health, such as fluoride and fluoride varnishes through their physician's office. And this gets to be a very, very important service for seniors to get them back into their preventive world. And I think that the preventive aspect is very important. One of the obstacles that we find for preventive care is the training of staff to do these types of projects. And one of the things that we're involved in frequently here in New England is training staffs in hospitals and training staffs in primary care and in clinics on how to use things as fluoride, sodium diamine fluoride to prevent caries in seniors. Could you advance that again for me, Chris? Thanks, Christine. This, one of the studies that I think is such an important study that shows the great relationship between dentistry, oral health, and primary care are some of the recent studies that were released through the insurance agencies. And what they showed is that by treating certain types of disease, periodontal disease, you could actually have a reduction in the medical costs for patients. We had been looking for these studies for years because it's that connection where we can actually say to government and to policymakers that if we can manage periodontal disease, we can decrease the cost of treatment for diabetes and for stroke and for many other issues. And so for those we are dealing with diabetes in your clinic, it's very, very cost effective to have periodontal treatment as part of their diabetic care because it does a couple of things. It makes the management of the diabetes easier and more efficient and cheaper. Now, a lot of these studies, the reason we don't have a lot of data on seniors is that most of the money for research was not invested in that over 65 group. We're starting to get data coming back from that. But this is the type of data, and why it's so important is this is what's going to change oral health policy. Because one of the obstacles of care is not having information to change the policy that affects all of our clinics and all of our patients. The second to treating gum disease reduces hospital admissions it's a tremendous cost, savings. So not only does it prevent episodes in your office, but it prevents those senior patients going into the emergency room and reducing the costs of care. So the connections are finally being made between what physicians do and dentists do, and vice versa, what dentists do. It relates to what the physicians do. So it's an exciting part where we are today, because up until probably the last couple of years, we've all been our own silos, where the dentist, we do all our work without looking at our counterparts. And what we're doing today is we're finally opening up some of the windows and seeing what happens in the different types of clinics, or what happened in California. And so it's very, very important. One of the great obstacles that I see as I travel around New England is when, especially with your clinics, if you have a dental emergency, who do you refer to? And that is a real issue here in the Northeast. I would love to have some feedback from your standpoint, but I think we'll get back into that echo. But what I see is that if somebody comes in and needs a dental referral, they usually will end up in the medical office, or they'll end up in emergency room care. I'm in the state of Maine, and the amount of emergency room visits from seniors have gone through the roof. And so their treatment of choice is not dental care for their mouth. Their treatment of choice is going to the emergency room for dentistry. Now, it's not a very efficient way of care, because statistically, if you go once to the emergency room, most likely you're back 4 more times during that course of the year. And so instead of taking care of a problem, we now have a problem that's kind of ongoing. Now, that information and that data is also another important part of one of the greatest obstacles of care is health policy, oral health policy and integration. So having this information gives us the ability to make a change. Next slide, Christine. And I think this slide just speaks for itself, and I just wanted to place that on there because I know we all deal, especially from the medical standpoint or dental standpoint, chronic diseases. And all chronic diseases affect the mouth dramatically. With the medications that we take, the medications that we prescribe, most all of them cause dry mouth or taste disturbances. And any of those diseases that are affected through dry mouth or taste disturbances typically will cause either gum disease, or they can cause caries and decay in teeth. This is especially important for the behavioral sciences. Many of the patients with eating disorders or severe mental disease, obsessive compulsive, have medications that will directly affect their teeth. So when we look at our team, we have to be able to kind of look out of our silos as dentists and physicians and see how what we all do affect everyone else's discipline. And I think that is one of the goals of this program, is to be able to get out of our silos and introduce each other to everyone else, so that we know, for instance, if someone is going into a behavioral scientist and putting a patient on certain medications, what I would like to see is to have the prescriber look at the patient who's getting the medication and let them know that this is what's causing, this could cause dry mouth, which can increase decay, and you need to have a referral to your dentist. At the very beginning of our talk today, we talked about the perception of care. If people perceive that there can be a need to see the dentist, and it comes from the nurse practitioner or from the physician's office, they're more likely to come into the dental office. So we all sort of work hand in hand on this. Next slide, please. I think this is a very important slide. It's from the University of Massachusetts Medical School and Dr. Yusil. I'll give you permission to use this. When you look at the over 65 group, that 85% of seniors may get to the physician's office, but most of those patients that go in to the physician's office or in the clinics most of them do not have scheduled dental visits. So that's why integration is so important. To point people in dental care and oral health is definitely going to be the accessory clinics that may actually be the first point of contact with these patients. So just this slide alone shows that if you have 80% of these seniors going into your clinic, they may not come or may not see a need to come to the dental clinic unless there's an emergency. So we can make a big difference by sort of working together on this. And when you look at our role as in the dental office, one of the things that we can do is if somebody has, if we have a patient that has a behavioral disorder and they're on medication, we may pick up the side effects of these medications, and we need to be able to refer them back to their primary caregiver. We will see potentially signs of diabetes or heart disease. We may see nutritional issues, and we will see them and pick them up dentally. And instead of just looking at a senior and saying you need to see your physician, we need to be part more of a team where we start to make follow-up phone calls so we integrate our information. May I have the next slide, please? This slide here just references a little bit of what we just talked to, that it's very difficult for physicians to make a referral in almost any state in the United States. And a lot of that is you can make the referral, but most of the dentists, with their fees may prohibit the senior from coming into their office. It's very difficult to get into a dental office. If you happen to have Medicare that will cover certain services, there are many dentists that may not cover, that may not take Medicare patients because the reimbursement is low. So this is one of those systems that is broke, and this is one of the referral process is one of those issues that definitely has to be looked at and new models of care developed. And there are a number of different models that are being advocated now, and we can chat about those towards the end. Could I have the next slide, please? This is a slide from Dr. Fichuzek, and he was the graphic that I used when we were looking at the different reasons why people do not come into the dental office. And it was through the ADA, but one of the things, there are two important points on this slide. It's affordability and it's the perception of care. And those are the two areas and the two greatest obstacles that pull people back out of the office so that they don't come in for dental treatment. And the reverse of that, we have to also be aware that over 65, most of the patients have at least one chronic disease or more. And so we're going to be looking in the dental office at the side effects of many of these chronic diseases. We need to be able to identify them and integrate our care with physicians. We need to be the point source to refer them back into integrated care. Next slide, please. The philosophy a few years ago, from the dental community is that if we put more dentists out into these geographic areas, we'll get more people coming in to the dental office. And what happens, we know that we have reached sort of a saturation point, that it's not so much now how many dentists we have. It's going back to the slide previous on Dr. Fichuzek. It's really based on the efficiency and cost of care and the perception of need. So whether we have more auxiliary care, and there's a number that are coming into the workforce, or more dentists, we still have to look at the greatest obstacle of care. The greatest obstacle of care still is finances. Can we go to the next slide, please? I don't know if we'll have echoes when one of the questions I would have for you is that what do you see when you're making referrals for your patients? What are your greatest obstacles in getting your patients out to a specialist? Can you? Can they be seen efficiently? Or do you end up taking a dental complaint that you see and end up referring them to a medical counterpart? Is it possible to get some questions on this without getting the echo, Christine?
Let's see, because I think that the lines are open unless Rosa and Stephanie have muted themselves, which is a possibility. And so if you, Rosa and Stephanie, if you want to go ahead and unmute, and we'll see if we continue to have an echo or it may have abated.
Okay.
Okay, I'm unmuted as well.
So far, so good.
Oh, that's good. Great. So just a question in terms of obstacles. If you have patients or seniors that would need certain types of care, do you have a referral source? Would you be able to refer someone out for care?
I can say for Family Health Services, we do have a referral process. Our issue is we kind of have to assure that their patients referred out are receiving, you know, a similar discount for services that we provide under the FQHC model. So that makes it sometimes difficult with specialists because a lot of them, I mean, we're pretty lucky. Many of them will accept like a Medicaid rate or something. You know, we do have some partners, but because we're spread out so far, we don't have that partnership in every community where we have a dental office. In fact, we are the only dental office in a couple of our communities.
That's really interesting, because that is an obstacle that we find around the country where it's very, I know in Maine it's very, very difficult to be able to refer out, and many times they end up back in the emergency room actually for getting treatment. The treatment tends to be an antibiotic and also a pain med, and gets to be their choice of treatment. Any other obstacles? Anybody else on the line?
Well, if it's for dental, here for neighborhood health, we have our own dental clinic, so our patients are basically seen right here. But if it's for any other type of referral, we also have a referral process, and we do have agreements with, say, like a major system like Innova here in the East Coast and in Virginia anyways, and they do tend to see a lot of our patients for different needs.
I see. That's interesting. You know, because you both seem to be in situations that tend to work fairly well. We have some clinics in Maine, but by and large, most of the population still, I say 70%, really have very poor access to care. Could I have the next question, please, Christine?
Yes. Oops.
When you're getting ready for an integration or changes, how I have just a curiosity in terms of are the staff, is it difficult to get the staff online and be part of the team? Are they nervous about that transition? And how did you deal with that transition? Because one of the things is people tend to integrate care. It's that nervousness of the team. How did you solve those problems? I would be very interested to hear from you on what makes your team work. What about your team, Rosa? What works in your team? Do they have staff meetings or special education, certain types of educational modules? Is it the leadership?
I think you said it earlier. I think it's leadership. I think that when the leaders of the company, of the system are ready to implement, and I'm just thinking about the diabetes program here, when they are ready to focus on developing it, then I think that they find a way. They find a way of getting all the players together, the time, the training that is needed. It needs to start there.
You know, and if you have questions, if your team is developing this diabetes portion, I think what you'll find is going to make a large difference in your patients in terms of their management, but also financially for the clinics. If you have any questions at all as you go through this, please call. This is very exciting for me. So as you kind of go through this next phase, please use me, call me. We have lots of information, and on a call like this, especially when you're not in person, there's lots of data, and it's data, I think, that works. You know, from a clinical standpoint, some of the hesitation from the administrators is it's going to take more time, and more time is going to take time taking, you know, your staff away from other patients, and financially it may not be workable. But there's a lot of models that show that not only does it work well once it gets going, it's good for everybody. And one of the things that I'm always impressed with is just how well the staff do. They like challenges. They just want it to be an organized challenge.
Right. Yeah.
Any other comments on just the getting ready for OLAs coming in? What about in terms of electronic records? What do you do in your office from a physical standpoint for seniors? One of the things that I have noticed is that when we see seniors in the dental clinic or in medical clinics, and we prepare for them before time to make sure that their visits are very efficient, because just the time that they have in the chair. But one of the things that has worked really well in terms of integrated care is to be sure that team members are calling these seniors when they leave, to be how they react to drugs, or dental treatment, or medical treatment. And that's one of the ways we always get ready for seniors coming through. And I think that, to me, is a great tip, is the follow-up, because it's when, if we have a medication that we give in the dental office or in the medical home, once seniors get home, they may not be able to afford the drug, they may take it wrong. And what we worry about is, as I'm sure you both can attest to, is when seniors get home and they're older, they fall. And so they can leave a dental office with a small filling and end up with a broken hip. So it's that follow-up call that can be so important. Do you have any other suggestions on ways that you personally got ready in your clinics?
I can't really speak from the clinic perspective. I'm in administration, so unfortunately I don't have that insight. I would love to have one of our dental staff able to answer that. But I know that they're very conscientious of our patients. We see lots of refugee patients and have to make special accommodations. We have special needs dental patients. So I know that just kind of being culturally and aware and sensitive is kind of a big part of what we do already.
So with your administration, what challenges did you face as an administrator with the integration? Was that?
So, integration is always, there's always the financial piece of it, especially with an FQHC, because, you know, we receive a large portion of our funding from the federal government. We're very bound by how we use that money, and then our program income goes back into our patient care. So financial is always a factor. We have to justify, you know, pretty much every dollar we spend, why it's being used here and not here. I think the biggest problem is bandwidth at this point. We have grown so much, so fast, and we're being I mean, we have actually been contacted by Title X and housing for HIV patients and all these different external organizations on a state level that we have never really worked with before, who have come to us and said, hey, we really want you to participate in this program. And we're like, okay. You know, so we have a lot of that going on, and we're kind of trying to navigate how to implement anything. It's more, do we have the human bandwidth to handle the extra training, the creation of workflows, data validation, data reporting, all of that goes into play. So that affects every kind of integration that we do, anything.
How do you manage the training? Because you have a lot of personalities. How do you manage? Is it like a module? Is it a lecture?
No, a lot of our training is they will do like a monthly dental leadership and a dental staff meetings. Then they go out to the clinics and they have the meetings back there as well.
That's tremendous. That's great.
Yeah, our clinics that actually are doing dental integration in the medical clinics, they also have a little meeting with the medical clinic. So that targeted meeting time is really important to kind of hash out the different problems they're running into.
When you bring in like an educator, are the different members of the team, would you bring in, say, a pharmacy or a dental or medical? Is it like a multidisciplinary type of training so that you?
Not usually, at least not yet, no. We do have, so we've been really lucky to be a part of a couple different pilot programs. So we did the DentaQuest Institute Caries Free Collaborative a couple years ago. We were one of 14 organizations across the nation doing that. So we really had a good pool of just a learning crowd of professionals working through that. And then we're currently working with the Cambia Health Foundation on a grant. So grants help these processes because you just kind of introduce it piece by piece, figure it out for a year, and then, you know, hopefully you've gotten through all the glitches by the time you roll it out to the whole organization.
When we look at obstacles to care, are there issues that you would like to deal with specifically? And I guess a follow-up question to that would be, when we have these types of sessions for an hour, what would be the most efficient and the most beneficial for you as we go through this time period together? So is anything specific, like as an obstacle you would like to deal with? There is a series, and sometimes when we look at this, when I was preparing the lecture, I literally spent probably 6 hours with different facilities to find out what in the real world is. It may be like in a situation like this, if you're an attendee, if there's specific obstacles, you know, to send them in, we would maybe to deal with those. Because I know geographically they're definitely different. In Northern Maine, it's definitely geographics along with finances, and in other areas it's strictly just the finances. But what would make these types of visits for an hour more profitable for you?
I know personally one of the big challenges we deal with in this area, because we're spread across such a large area, is lack of transportation. We have like almost no public transportation. We have a couple taxis and a transport bus system that works in our big Twin Falls area, but our outlying communities really have no public transportation at all. So transportation is a big deal, and in coordination with that, kind of telemedicine, which is really hard to do with dental. So I don't know. We're kind of inching towards that now with our medical and pharmacy services. So I don't know, any cutting edge information you have on that, I know would be beneficial for us.
Have you worked with, or has your contacted like Dr. Paul Glassman in California, who really was the kind of the father and the guru of teledentistry? The amount of changes that's occurring with that and how it can be useful. So essentially what you have, you still need to go to a patient and to make that so that it's more productive, what we look at is the homes are different. So we may go to community centers where there's a group there, and then that's where the teledentistry is done. It's not very effective as a model to go from one house to the other, even though it's done. Right. But it's great to be done. But yeah, that's changing dramatically. That's a great question. I think that would be something, how do you access and what's the most efficient way? And maybe that's something that could actually be addressed. I know we have a few minutes left. Any other questions or comments on what makes this more productive for you? Because the goal of this is really to make this work, to get information. I mean, I learned today from everyone here just the best way to exchange that information. Christine, you can bow in any time here. I know that I only have like 20 minutes or so, but
yeah, it's okay. And certainly we'll be addressing specifically, or I should say more specifically in the next session in terms of integrated training and care delivery, where the focus will be on oral health. So we can certainly continue this conversation. And particularly, Stephanie and Rosa, if you have specific questions that you would like to have addressed, please send those to us so that we can think about that and provide more specific information to you with that respect. Okay. And then we'll also make the slides available as well. Do you have any other additional questions? I know we have 2 minutes, but I just wanted to make sure if there was something burning in your mind that you wanted to put out there before we ended.
I don't have anything else. No.
Nothing here. Just want to thank you for your time.
Great. Well, thank you for sharing that. Yeah.
Thank you for joining us, and thank you, Dr. Brennan, for providing the information today. And it is 12:59, and so we will end for today, and we look forward to having you back at the 3rd session. Okay.
Okay, thank you.
Nice to chat with you.
Thank you,
Rosa,
everyone.
let me know how you're doing with the diabetes. That'd be very interesting to know that.
Certainly. I will keep you posted.
Great. And Stephanie, I'd love to hear more about the possibility of the teledentistry. I'm involved with some of that now, and I work with Dr. Paul Glassman in California. I'd love to share that information with you. So you can send an email, or we can even chat by phone if that's easier for you. But I'd like to follow up on that.
Okay, sounds good. Great, thank you. Thank you, everyone.
Have a good afternoon. You too. Bye-bye.
Bye-bye.
Bye.